talk through like early pregnancy stuff, nutrition, weight gain, and then the different forms of abortion, miscarriage, ectopic, molar, and then previa and abruption. And then you guys can tell me what you need. Besides that, does that sound good? Is there anything you definitely want to talk about that I didn't?
Carmen was coming, I think.
Did you mention like the? Oh my god, I didn't think of it. Like the strep B and like all those things.
Yeah, we can talk about fruit strep.
Yeah, because she was like talking about like those stuff.
Okay, so the GTPAL. Okay, so we have G, T, and L. And on the floor, we simplify it and we just do G's and P's, right? That's what you guys have been hearing on the floors.
Mm-hmm.
Yeah.
So what is G?
Greta.
Yeah, and what does that mean?
How many pregnancies?
Yep, number of pregnancies. What about T? Term. So what is considered term in pregnancy? Greater than or equal to 37 weeks for this case is considered term. Now we have early term, full term, late term, but you guys don't need to know all the specifics. So greater than or equal to 37 weeks, number of pregnancies that have delivered at that gestation. And then what about P? Preterm. So what is greater than what? How many weeks is considered preterm delivery but not an abortion? 20 weeks. So this is between 20 weeks and 0 days to 36 and 6. So the day before 37 weeks.
So 20 weeks to 36 weeks?
Yeah. So they delivered at that gestation. And then abortion is anything under 20 weeks. That covers spontaneous, elective, ectopic, any pregnancies that end less than 20 weeks. It's really bad too. And then the L is living. Number living children. And that's current living children, not living at birth. So if I have a twin pregnancy, and it's my first pregnancy, I'm a G1, and then once I deliver, if I deliver at, let's say, 36 weeks. So I'm a G1, P1 on the floor, or a G1, term 0, preterm 1. Abortion 0. Nope, you can sit there. And then number of living is 2. So we still only had 1 delivery. So our preterm is still 1. But our living is what changes with twins. So no matter how many babies there are, you only get to add 1 for each delivery. But on the floor are G's and P's. P is just number of deliveries over 20 weeks. So it's kind of this term, preterm combined is where P's on the floor. Para is what it stands for. So you'll hear para or parity. So if you hear people say primate or multip, that's what they're referring to. Multi-para is multiple deliveries.
Can you put it on the table, maybe? So you don't have to hold it like that.
See it? No, you don't see it.
There you can.
Yeah, just so I can't see what my.
What if you move your chair back? Yeah.
Okay.
Yeah, it has wheels. Or wait, what if you put it right here?
Okay. Well, then you can't hear her.
You won't be able to hear me across the room. Sorry. I need a microphone.
On Emily's table.
Okay, does GTPAL make sense?
So for GP, you said when you combine the T and P for.
Yes, so when you hear gravida and para is combining term and preterm, so anything over 20 weeks that is delivered.
And then abortion was.
Less than 20 weeks. Any loss of pregnancy less than 20 weeks.
So what was it that she was saying about like past viability in class about that?
So viability doesn't necessarily have anything to do with gravidas and paras.
I just heard her saying that in class and I'm like, what?
So viability is going to vary between hospital. That's why we don't use it. We just kind of across the board use 20 weeks.
Okay.
Because the U of I will resuscitate 22 weekers. Even they're hitting like the 21 and a half weekers at the U of I because they have an amazing NICU. Unity Point, we're at 23 now, which is better than like when I first started 11 years ago. We were closer to 25 weeks. So that is all a matter of your neonatologist, their comfort level, and the equipment because they have to be able to intubate them. So that's the challenge is intubating. You can imagine like a less than 1 pounder how challenging that would be to intubate, which is why I just want nothing to do with babies. Mom is me. Okay, so if she had twins, but then one passed away from SIDS, we would change her living to 1 the next time she came in. So living children is number of current living children. We reassess that every time they come in, or we should reassess it every time they come in. But yeah, that's our only indication that we had twins, is the number of living is usually higher than the number of term or preterm. Okay. Then let's talk about nutrition. What are the big things that we need to make sure our moms are getting, especially early in pregnancy?
Folic acid.
Folic acid. Why do we need folic acid?
Neural tube defects.
Neural tube defects. Yep. What else are we gonna make sure our moms are getting?
Calcium.
Yeah, calcium's about the same actually, pregnancy, non-pregnancy. What else?
Increasing carbs and protein.
They do need to increase their total number of calories a day, but iron is the thing that we really need to make sure that they're eating a lot of. They have an increase in blood volume, and in order to get oxygen transferred to baby, they need to have red blood cells. So big thing is iron, so know your iron sources, know your folic acid sources. Those are the big things. What about weight gain? How much should we be gaining?
Less than 4 pounds a week.
What about just total
Oh.
during pregnancy?
I think actually just 4 pounds a week. Like 35 pounds.
Total 25 to 35 pounds if you're an average size person. Normal BMI. If you hit the overweight category, you're gonna hit more like 15 to 25 pounds. If you are considered obese, you're gonna hit more like 11 to 20 pounds. And underweight, you get to gain 40, so you get to really increase your calories.
You said obese was 11 to what?
20. So your normal though, 25 to 35. Overweight, 15 to 25. So those are your like big nutrition things. Okay, how do you confirm a pregnancy?
Blood test.
Blood tests, yep.
HCG or whatever.
Yep,
it's
so HCG in the system is going to confirm that you have a pregnancy, but I believe your book talks about fetal heart tones on ultrasound and fetal movement felt by a provider. people have fetal movement even when they're not pregnant. Just psychologically, sometimes they feel it, even though there's not a pregnancy there. So your definitive is ultrasound and fetal movement followed by a provider. Otherwise, there's multiple different ways that we can predict that you're probably pregnant, just period. HCG, increase in fundal height, different coloring of the vagina. All things that might indicate pregnancy, probably indicate pregnancy. Okay, so we've confirmed pregnancy and then we start bleeding. Does vaginal bleeding necessarily mean that you're going to miscarry? What are pretty sure signs you are going to miscarry?
Severe cramping.
Yes, severe cramping can be. What else do we think?
Water breaks.
Yep, your water breaks or your cervix dilates. There's not a lot we can do. I have seen people rupture at 15, 16 weeks and still make it to viability, but that lung maturity isn't necessarily there. They need that fluid in there to have those lungs mature. So otherwise it's considered threatened with cramping and bleeding. What about ectopic? I'm starting deeper. I have notes, but mostly I do it off the top of my head. Okay. Ectopic. What is an ectopic pregnancy?
Implants in the tube.
Implants in the tube, but it can also implant anywhere else in the abdomen. So outside the uterus is going to be an ectopic pregnancy. I've heard of them implanting even on other organs, but unless they are in the uterus, it is not viable, unfortunately. We cannot just move it into the uterus. Despite what some politicians have said, we cannot move them from outside the uterus to the inside the uterus. If we could, that would be fabulous. We would all love that, but we can't, unfortunately.
It's not illegal to fix an ectopic pregnancy, is it?
It's not illegal, but they're saying that you don't need surgery, you don't need an abortion because you can just move it to the uterus. Yes, this is why people who are not physicians should not be making decisions, but that's for another day. Okay, so what is our big concern with ectopic pregnancy? What is your mom at high risk for?
Death?
Yes, from what do we think is going to happen? Outside the uterus, it keeps getting bigger and bigger and bigger. What's going to happen if it's in the tube?
Bleed.
Yes, they're going to hemorrhage. That pregnancy is going to rupture that tube and they're going to bleed internally. So we're really, really looking for signs of hemorrhage. So obviously it can damage the tube if we don't catch it early enough, which can impact future pregnancies. What do you think might cause an ectopic pregnancy? It might cause it to get stuck in the tube versus continuing to travel through the tube to get to the uterus.
You have two releases.
If you what?
Two releases of eggs because you have two ovaries. So
Yeah.
Like scarring.
What about if you have scarring in the fallopian tube? That's going to prevent that pregnancy from traveling along the fallopian tube and into the uterus. There's Barbie. Okay, so some things that might cause scarring could be previous ectopic pregnancy, previous surgery in that general area. Infection is one thing that can really cause scarring in your fallopian tubes. So previous infection, especially like sexually transmitted infections. What are we gonna look for signs of ectopic pregnancy? Sharp pain in the side, either side. Really bad pain or cramping. They may have some spotting, but they're not gonna usually have like heavy bleeding like you would see with a spontaneous. Questions about ectopic? Ooh.
Sorry.
Oh, I was gonna say, it sounds like mine. Okay. Let's see. So we're looking for hypovolemic shock on those patients. What are signs of hypovolemic shock or like hemorrhage on our patients without actually visibly seeing it?
Low blood pressure.
Yep, it's gonna be the same as in our adult patients. So low blood pressure, high pulse. May see them be like cool, clammy, pale, decrease urine output, all those kinds of things that would be the same as your adult patients. And our last kind of abortion, miscarriage, molar pregnancies. So what are molar pregnancies?
It's not a baby. Just
Right,
stuff.
there's not a baby. Usually no fetus forms. Sometimes there's a placenta, but essentially the cells just go crazy, right? They just spontaneously keep mutating cells. So your uterus fills with all these essentially precancerous cells because it can turn into cancer, especially on a complete molar pregnancy. What do you think a sign might be of a molar pregnancy? We're super cells in your uterus, so what's that gonna cause your uterus to do? Expand, right? So your uterine height's gonna be higher than what would be typical for your gestational age. As with all things completely diagnosed by ultrasound. So spontaneous, ectopic, molar, they're all gonna be diagnosed with ultrasound. But we can feel like, okay, more than likely this is what we're looking at. I might also feel like, oh, yep, that uterus is bigger than normal and it's not a molar pregnancy, it's a twin or triplet pregnancy. Those are also gonna cause our uterus to be larger than normal. So nothing definitive until we have an ultrasound.
Got a chair for the
I got no chairs.
This
No use
one
chair.
over here.
Sorry.
That's okay.
Okay.
We talked about the GTPAL
Mhm.
some more. We talked about nutrition, folic acid, iron.
Well, and you know, what the other thing is, guys, they do use a lot of abbreviations in obstetrical places
Yes.
that might just be something that somebody sort of,
Made up.
yeah. And so if you see something that you don't recognize, I've had it happen where, okay, yeah, I'm not
Yeah.
sure that either. So we can ask about it. If you ask a question and you think, oh, I should have known this, you might look silly for a minute, but if you go ahead and do something without asking and it's not what you know, it stays with you forever. So just remember, even if you look, I've looked silly many times.
Yeah, me too.
So ask, because there is some kind of weird stuff that goes on in the abbreviation.
Yes. We have all kinds of.
And you might have people that, it sounds nicer to say miscarriage.
Mhm.
It's not really a scientific term,
Yeah.
but you might have someone that says miscarriage. And I don't know, did I tell my group, if you see the rose on the door, what that means?
Yeah.
Okay,
What does that mean?
okay, my people, explain. What?
The baby died or stillborn.
Yeah, fetal demise. So if you see that on the door,
Okay, so then previa and abruption. So what's a previa?
The placenta implants at the bottom.
Yes, so here's our lovely uterus. Just a fabulous drawing.
it's not that's not a hot air balloon, guys.
Right? Uterus. Here's your cervix.
Hey, let's see this.
Right? Cervix. I had a computer up here. Okay, so here's our placenta. Our placenta implants over our cervical os. So we're gonna have complete, which is completely over the cervical os, partial, which is just partly over our cervical os, but essentially over the cervical os. So what's our risks for this? What are we looking for in these patients? What do they usually come in with? Bleeding. Yep, so why are we having bleeding? We're over the cervix. So what happens every time anything happens with that cervix? Anytime it's any kind of stimulated, and the cervix is very vascular, we're gonna bleed, right? Because we're separating here, right over where the cervix is. So usually painless bleeding. If they're contracting, it's not gonna be painless, but if they're contracting, they're gonna bleed. Are we gonna check these patients? Why not? Yeah, because what's gonna happen if I stick my finger right through this? You're gonna hit that placenta. You're gonna cause massive bleeding.
Or you might go to the edge of it and dislodge what might be attached to something else, else to it. So what happens with you if you've got somebody that's a preview? How are you gonna deliver the baby?
C-section.
Right.
Just can't deliver.
Now, one of our anesthesiologists said something yesterday, and you probably have heard this before. The big tall guy, I don't know if he's
Leave it up.
that has a funny, always a funny hat, and he's really tall. He has people in their sides,
I think he can.
Yeah, leader house.
and
He's older.
he says his rationale, if you're getting a spinal, lots of times people have, they sit up, but for a previa, you really don't want that person sitting out previals. So he would like a person on your side to do their spinal, if you had time. Those people you may not have time, you may have to do a general, but most of the time, would you say in your practice, most of the time you can do a spinal, or what do you say?
Yeah. Yeah, most of the time.
So it may be that they want the person to lay on their side and kind of curl up like a ball and jut their back out that way.
What's gonna determine if we deliver these patients, do you think?
If it's completely blocking the cervix.
Yep, so we'll have to eventually deliver them by section, but why if they come in bleeding, how are we gonna determine if they're gonna be delivered, if they come in bleeding?
Contractions.
They're having contractions, they're probably bleeding more. So your patient comes in bleeding, what is the first thing you're gonna do when they come in? I just present to you in triage and I'm bleeding, and I have a history of previa. What is the first thing I'm gonna do? Walk them into the room and do what?
Ultrasound.
I cannot do an ultrasound as a nurse, but how can I see my baby? How can I know what my baby's doing?
Fetal monitor.
Yep, I'm in the fetal monitor for my baby. Just in general, if a patient walks into triage, our number one priority is fetal heart tones, because we have 2 patients and we have no idea what this one is doing, right? So we're always gonna put baby on the monitor. So if I put my baby on the monitor and my heart tones are in the 90s, it's probably gonna be said and done, right? I'm gonna call my friends and run her to the OR. But if my heart tones look okay, what else might determine if I'm gonna deliver?
mom's not doing okay.
Yeah, mom's not doing okay, so because of bleeding, we're gonna look for that. The signs of hemorrhage, right? So we just talked about low blood pressure, high pulse, we're bleeding too much, we're concerned about mom's well-being. And with those two things, we're also gonna think about gestational age. Are we viable? If I'm 22 weeks and bleeding a lot and my heart tones are in the hundreds, am I gonna run back to the OR? Not necessarily, because I'm not gonna be able to save my baby anyways, so we're gonna watch and see. As long as mom's stable, we're gonna watch. Does that make sense?
By the way, when she just talked about your pulse and blood pressure, hemorrhage, doesn't matter what's causing the hemorrhage, those are signs of hemorrhage, guys. We try to, you can't, and the reason we want you to really understand these risk things is because you may not decide you want to be an OB nurse, but you need to recognize, A, first of all, hemorrhage, but B, what could be happening with your patient. But that's a universal thing. If somebody's hemorrhaging, that's what they're doing. Whether they've had a car wreck or whether they're at a previa, and you're gonna probably right away, if a person comes in and they've got a previa, you're gonna probably say, okay, the previa is probably causing this and that's what's causing these vitals and that they're hemorrhaging. But that's what sign you see in hemorrhage. So you can't compartmentalize, you have to think of what's happening in the system, and then you think of what's causing this. We know this patient's here, we don't think they've had a car accident or they've gashed their, have a big cut or something, but it's due, they're hemorrhaging to do this, but look into context. Assessment is contextual. Where are you and what could be happening here? So just that we really want you to understand what could happen with an emergent case, because maybe you think you're gonna be, oh, I'm gonna be a med surgeon or something, I don't need to worry about that. Well,
We don't want them on the OB floor till they're 20 weeks.
Yeah.
We will get them.
so you will get people. Or you get someone in the emergency room and this person is presenting. Or, even just a person coming in that needs an appendectomy, you're in the operating room and you're the OR nurse saying, I don't have to worry about this. Well, yeah, you need to recognize things that are going on.
And appendectomies happen to pregnant patients.
Yes, they do.
You will see
Quite
pregnant
frequently.
patients. I almost guarantee it, no matter where you work, you are
My
gonna
line
see.
is, unless you're in an all-male prison and they figured out how men can actually have babies, you're gonna run across somebody.
Yes.
School nurse, whatever, you're gonna run across somebody, and the key is have some base knowledge here.
Especially in Iowa, where we are kind of a OB wasteland, they call it, because we
I
have.
didn't know we were called that.
Yeah, because we have so few OB units in the state of Iowa. They keep closing them because there's not enough
Small
patients
places.
to make sense for the staffing. Because you always have to have 2 nurses on a unit. So they have to staff 2 nurses and a tech on every unit that has an OB unit. Well, if I have 30 deliveries a month, does it make sense to always pay for 2?
Well, and the
Okay.
expertise, when you're not doing something all the time, and this is a specialty, but you still need to understand the basics, and you need to understand what's an emergency. But to be a primal OB nurse or a labor nurse, you need to do it all the time. Just like they used to let family practice come in and deliver babies, and I don't know if they used to have
They do.
GPs.
They
They still left that somewhat, but they're in a unit where people are maybe more of a know-how because these smaller hospitals have shut down.
Yes, so Lutheran, everybody know Lutheran used to have an OB unit. Until 2020. It was actually already planned before the pandemic just happened to hit, but they closed in the summer of 2020. So all their patients now come downtown. Few have gone out west. The midwives started going out west after that, but their family practice residency was at Lutheran and now it's downtown. So you may see family practice doctors. And they will ask a lot more questions, you will notice, of the nursing staff than like our OBs.
They really rely on the expertise of the OBs, the nursing staff. I
Yeah,
think.
especially in the triage
Yeah.
area. The other thing about previa is the bleeding is spontaneous start and stop. Usually we don't know what causes it and we don't know what stops it.
When people can have initially a marginal placenta, which is marginal placenta, sometimes it will move up. You know, but we have the benefit of having ultrasounds. In the old days, we didn't have the ultrasound. The person came and called you, didn't have an idea where the placenta was. So you had to really be looking. But we have those tools, so.
Yes, so our marginal, where it's 3 centimeters or less away from that cervical os. Eventually, as the uterus expands, sometimes the placenta will grow with it and grow up the side of the uterus. I had a marginal with my third.
But it can resolve.
Yes, they told me 2.5 centimeters. They were not.
Well, the other thing is, guys, you may not have any record on this person.
Yes,
Some people don't get prenatal care.
yes. Last church shift, I had no prenatal care. Came in, history of a bleeding disorder that even anesthesia had to Google to figure out what it is, to figure out if he could even do a spinal, and she ended up in the main OR. 2 IV lines, an art line, general anesthesia, because they figured they couldn't do a spinal with no prenatal care.
They call downstairs for anesthesia.
We
Did you
took her
guys
down to the main
Oh,
OR
okay.
because
Say art lines.
that didn't have any business being on our floor.
No,
That's
you're right.
that they need anesthesia tech help, and
Yeah. Well, they
I am anesthesia kind of tech help, but
Yeah.
not.
I know,
fabulous.
but yeah, an art line, there's something to setting that up, and
So, and no prenatal care, just came in high on meth.
which makes it important. We talk about these ways of knowing, you guys. We're not just talking for our health. That's because you need to look at everything and be observant. You may not have a record in front of you. First things to do, I went to their labs. You don't have any of that. So what do you have to do? You have to look at your patient and see what's happening. And
Triaging.
that's why you're getting that. Critical thinking is paramount to your practice.
That leads right into my placental.
Oh,
infection.
gee, well, okay.
Because you know,
We did map this out, didn't we?
right? So I like to tell my story of when I had a patient. It's
Oh.
been what, a
It
year
was
and a
last
half
year,
now?
it was last year, I think.
Yeah, year and a half, I think. Yeah, had a patient. I was charged. Took over at 3 o'clock. Don't ever take over at 3 o'clock on Friday. 3 o'clock on Friday. Nothing's happening all day. A couple labors. I get a phone call from triage. We need you down here now. So I run downstairs, and this patient walks in and passes out in triage, and is actively bleeding. We don't know her name. Don't know her history. We don't know her gestation. She just walks in and passes out, and now you have this patient. What do you do?
And you don't say call for help again.
Yep, because I am the help.
She's the
So
help.
I have now called
And many
myself.
times you might be the help, yeah.
Yes. So you guys may hear an OB alert called overhead. So you guys have heard of codes. You've heard of the MET team probably in your adult health classes, where they're kind of the ICU light team, where an ICU nurse comes and they have a set of orders. We have an OB team that is an OB alert. So it calls our OB hospitalist, our anesthesiologists, our NICU nurses, which is key for us, and then our charge nurses, which usually we're in the room. So we just have to call, like pick up the phone. Yes, I'm in here. And then our surgical techs. You guys have all seen our surgical techs that are responsible for opening up in the OR. So essentially I get down there, I see this patient is passed out, throw her in a bed, I call an OB alert for upstairs because I know I'm going that direction. She's passed out and hemorrhaging. She has no business being in triage anymore. Triage is kind of assess things, and we know this is an emergency. So we get her upstairs to the room. First thing I do, like I said, heart tones, 80s. So we know our heart tones are in the 80s. By that point, she is conscious, which is helpful. And you know she's a nurse because she woke up and gave us like her history. Yes, this is my name, this is my date of birth, this is my health history. No, I don't have any issues with the placenta. You can always tell those nurses.
By the way, they're
And you
talking.
could tell her husband was a resident because he stood in the corner and answered nothing. We had no idea he was anything. We thought he was a family practice resident because he was like not saying anything. But turned out to be a surgical resident, but whatever. So yeah, so her tones are in the 80s. Mom is conscious now. We know she doesn't have a history of a previa. So now we're thinking placental abruption. Because usually our sources of hemorrhage and pregnancy is either a previa or an abruption. And what is a placental abruption? Move our placenta here. So we know that our placenta is attached to the uterus here. And we know it's attached and it's got all these little spiral veins going from placenta to mom. Those are supposed to be on the side and on the side of her uterus.
It's like somebody with a head
Right?
injury with an alien.
I know. Okay, you get the idea. What is happening with our placental abruption?
Detaches.
Yes, so part of our placenta here is separating. And it could separate at any point. It could separate in the middle and start to form big ol' hemorrhage right here. Or it could be here that it's separating and then the bleeding is actually active and is going to show up. Here we may not see any bleeding because it's completely surrounded by a placenta that's still attached. So it just keeps accumulating blood. But this one happened to be towards the edge, so that's why she's hemorrhaging. So the doctor comes in, I've called an OB alert, so everybody's there.
Well, you're probably giving the patient oxygen at this point in time, right?
We didn't even get to that point.
Or
We're
you
literally
just-
throwing an
you're
IV
just-
in.
okay.
We're throwing an IV
But
in.
if you could, oxygen would be
Yes.
appropriate, IV, because you
Yes,
were.
so while I'm checking heart tones, somebody else is putting an IV in.
Yeah.
Because those are big things. We know our heart tones are in the 80s and we know we need an IV. Doctor comes in, checks our cervix because maybe she's fully dilated. Maybe this is preterm labor and she's just dilated quickly and that's what's caused our bleeding. Probably not, but she was only 1 centimeter, so we consent her. Hey, your baby's heart tones are in the 80s. We think your placenta is abrupting. We need to go back to the OR for an emergency C-section. Patient says, yep, do whatever you need to do, as they usually do to save my baby. So we run her back to the OR. General anesthesia. Our anesthesia's already there because our OB alert has called them. Our NICU team is setting up.
That's a great unit.
Yes.
You're
So
not-
everybody's already on the floor because we have called this OB alert. So luckily we run her to the OR, and from time that I got that phone call to time handing the baby to the NICU was 18 minutes.
Got that very quickly.
Yes. So
And can you see why would we stop and try to do a spinal?
The baby needed to come out like fast.
Yeah, we didn't have time for that.
No.
There's no time to be, boom, we're gonna put that person under a job.
and we're in COVID, but does anybody have time to put on Pampers? So that's the thing about OB is before we were all fitted for N95s, and even after we're fitted for N95s, like our N95s are stored in our break room. Do we have time to walk back there? So at this point we're all fitted for N95s, but none of us had time to walk back. The techs could keep theirs on the backboard, so they were able to grab theirs, but everybody else is not wearing. And I am helping intubate, because that is a charge nurse's responsibility in OB, is to help anesthesia intubate the patient. So I'm just praying at this point that I am not giving myself COVID while I'm helping intubate the patient,
Sure
but
about this far from.
yes, I am right above the, but turns out she had the COVID vaccine, so this was prior to Omicron and all that.
Well, and this abruption can happen when the person's in labor.
Mm-hmm.
And I had this is my story of, and it isn't always completely evident on the strip, and went in the morning talking to patients to see about having students in there. And I went into this lady and she had an epidural, but she was having a lot of pain. That can mean, hey, she's dilating kind of fast and, but she didn't feel pressure, pushy, or anything like that. She's having a lot of pain. And I'm looking at her strip and I'm thinking, well, there's really nothing here that denotes this baby. So I'm helping her do some breathing, thinking maybe your epidural wasn't very effective. I hadn't been there all night. I just was getting there in the day. So kind of got they were Hispanic people, they spoke English, but not fluently. And so got over there with them and helped the husband kind of soothe the lady. And I went out and asked the nurse, this lady's in a lot of pain. I think, something might be going on. And that makes it awkward a little bit because I'm the nursing professor and I'm not employed there. And she goes, well, she's kind of been like that for a while. Okay. And 1/10 of me stopped myself from going and calling the physician myself. But she'd been watching this lady. I wasn't seeing anything on the monitor, but something inside me said either something's going on. She's either going fast or whatever. Well, then the day nurse came on, and that lady was starting to abrupt. So that was what's happening. And she ended up going back for emergency section. They cooled the baby. It was a good outcome. But it was nothing I had a fact other than what this patient was telling me. And I made a mistake, and thinking that the nurse was going to report this to the next person was going to react to it, saying, hey, if this continues on, we need to. And the other person did not. In fact, this person's not there anymore, but she was notorious for turning the pit up quickly. And
So can we as nurses
can
cause an abruption?
Yeah.
Yes.
That's exactly what happened.
Listen,
And
that Pitocin that we turn up, and we'll talk about this later, when we talk about Pitocin and labor and fetal monitoring and that kind of thing. But as nurses, we continue to turn that Pitocin up, and we have to use our nursing judgment. Is it appropriate to turn this Pitocin up or not? Based on how frequently we're contracting, how strong the contractions are. And the big thing is our uterus soft between contractions? If not, and if you keep cranking that Pitocin up, that doctor is at your bedside, you need to bump it up, you need to bump it up, you need to bump it up, because they want this patient delivered. It can cause placental abruption.
that really, I think in essence, ultimately, maybe it was starting, but maybe something was going on, and I can't swear to what was happening, but eventually she did have an abruption.
Mm-hmm.
And I had, so you're right.
Yeah.
Your actions can, and then I feel it's terrible guilt. Why didn't I go press it further?
Mm-hmm.
And that's a lesson to me of, what? And praise the Lord, we had a good outcome. Everything came out okay, but it did not have to be like that.
Yes, but you as the nurse in a court of law, they're going to say, why'd you turn your Pitocin up?
That's
You're
right.
contracting every minute, why'd you turn your
And
Pitocin up?
this lady's pain was out of control, and that's, whatever.
Yeah,
Excuse
so
me.
Sure, absolutely.
saying that the physician told me to is not good enough in OB land. You as the nurse get to control the Pitocin, whether the physician likes it or not. And I have been brought back to the backboard and informed that I am a nurse and they are the physician, and how dare I?
Well, and you guys, we always have to think about that you are a team with people, and
Yes.
fortunately, there's a lot. I think the physicians, honestly, from the old days, my dinosaur days to now, I think it's a little better.
Yeah.
They're respecting you, but if you feel something strongly and you feel you have reason to support your case, that's being a patient advocate.
Yeah, because in the
And
end,
not disrespectfully. I can assure you Lindsay was never disrespectful. She didn't say, you idiot.
I
or
did
you
not.
idiot."
I did not even.
But you know what I mean.
You're
But
fine.
you learn the trust of people, and then and not gloating when you're right either.
Yes, in this case, we did talk about the reasoning why. I had to justify why I said, because I was a charge nurse and it's a brand new nurse, so she's not. And I tell all the new nurses, like, you don't take the brunt of this. You send them to me and tell them I told you to do this because I have had the years of experience that you don't have. So they're gonna come after me, which he did. But I explained to him the half-life of Pitocin is 30 minutes.
Yes, it is.
It had been turned off for 45 minutes, so at that point we needed to start back.
You can't just go where you were before.
Yes,
You
so
gotta
he
start
wanted to start back at the high dose that we were at before we turned it off. And I said, nope, we gotta start back at the beginning, which, like I said, we'll talk about Pitocin later. But I explained to him why it was, and later that night he did come up and say I was probably right.
Well, and that's
That's
okay.
as
That's
good as you're gonna get.
Well, and the other thing, which brings on the point of, guys, that's why when we're asking you about drugs that we're using and things we're using, if you don't know your drugs, if you don't know what the contraindications are, if you don't know why you're giving it, if you don't know how you should be giving it, you need not to be giving it. You need to be, if you're unsure, have you ever looked up a drug? Of course you have. I've looked up many. And so if you don't know, and you should know your hospital protocols as well.
Mhm.
Because if you know those, when you get into a court of law, and they say, well, what's the protocol for this? Or what did you do here? Well, I didn't write that down. Well, you didn't write it down, so how do I know you did it? Documentation, and you know, this is not to scare you, it's just to make you conscious of your responsibility.
But yeah, everything we do can affect our patients, so.
Yeah.
In that case, yes, it can cause a placental abruption, so, signs of placental abruption are what do we think, besides bleeding? Cause we may or may not have bleeding. Severe pain, because we've got this big old hematoma forming here. It's applying pressure on our uterus. Pain. Not always. You can have painless bleeding with a placental abruption. All that blood is coming out, like this patient had no pain, but came in and passed out and hemorrhaged.
I think typically people do associate more pain with the previa than they do with an abruption. But you have to realize there can be pain with an abruption. I mean, I
You
just
meant
said that
backwards.
backwards. I just said that backwards. People, there can be pain with the previa. There
Yes.
can be pain.
Yes.
You're gonna pretty much always have that pain, but you also can have that bleeding. I think they think there's no bleeding, but there's pain, which can happen. But if you can see where if you've got that walled off, you're not gonna see any bleeding.
So we're not
So I
necessarily
just said that
bleeding.
backwards, sorry.
No, you're good. So
What's
Pain.
another sign? What's it, you remember the
that's another sign.
eruption?
Abruption. So we've got all this blood accumulating here.
It's like expanding.
Yes, it's expanding your uterus. So all of a sudden your funnel height goes up.
What is the fundus, you guys?
The top of the uterus.
Who said that? Answer.
Both of us.
What?
The top of the uterus.
That's right.
Top of the
So
uterus.
everybody, that should be the factor that everybody knows.
Yes, because we all felt the fundus postpartum. Right? After
Is
there's
this
no
the one
longer
that would be
bleeding.
hard as a table, like hard? Like
Yes,
very-
board-like.
Yeah,
Yep,
board-like.
board-like abdomen.
Well, I always say this is firm contractions,
Yes.
this is moderate, this is mild.
Yep, mild, moderate.
Because we didn't used to have all these fancy monitors, so we had to feel. And
Yes.
sometimes when somebody's really having a really good, you can see, and if it stays up there,
And then non-reassuring fetal heart tones, which we will talk about later in the semester on what non-reassuring fetal heart tones look like.
does anybody know what the normal heart rate is supposed to be for a baby? What's the range?
So
110 to 160.
That's what they've got in their mouth. That should be on the tip of your tongue.
110 to 160. What constitutes you guys talked about a reactive non-stress test in your book, I think, in this section. What do you need to have for it to be considered reactive?
Isn't it 2 movements within like 30 minutes?
20 minutes? Yep.
20 minutes.
So we have to have 2 movements, but how do they show up on the monitor?
In the heart rate?
Yes. What happens to the heart rate during movement? Acceleration, yes. So 2 accelerations in a 20-minute period is considered a reactive non-stress test. So what can cause the abruption? So we talked about too much Pitocin. What else?
Good fall.
Abdominal trauma. Perfect. Yep. Fall, car accident, anything abdominal trauma. What else?
Could it be like genetic maybe? Since we're asking for like the past.
Not usually genetics, but past history, so like a previous C-section maybe could. Usually that's more previa, but could.
What can somebody do to themselves that might not be a great thing that could cause an abruption?
Drugs.
Drugs. Cocaine.
Okay.
Cocaine.
Think of circulatory, and you're dealing with the circulatory aspect of this.
And then one other thing is real common, but we will kind of hit more on it later in the semester, but maternal hypertension, high blood pressure, same thing, circulation, which we will talk all about. Maternal hypertension is my favorite topic, is
You
what I
say-
wrote my master's project on.
What do you say? Internal hypertension?
Maternal.
Like previous to pregnancy.
During pregnancy.
Okay,
Yeah.
so just during pregnancy.
Yeah, so we'll talk about different types of hypertensive disorders of pregnancy.
Okay.
90-page paper on it when I
You did 90 pages on that? Wow.
45 typed and then 45 pages of slideshows and tables and
Okay.
That's like a
I'll have to
legit
see
book.
that sometime.
that's a book.
Yeah, we'll talk about, the high blood pressure is not a good thing for anybody, but in maternity.
Super common nowadays.
It's,
There's rarely a day when we don't have a patient on
Yeah.
magnesium
I
sulfate.
and I think part of that is, I think a lot of them went unchecked for a long time. I mean, I think we've got much better screening, much better people noticing it before we get started. People are getting prenatal care and they're getting care for this, or it's getting addressed. Or they're catching it. And so we get
A
these
lot
people
more
that
people with
come in.
hypertension before pregnancy,
Yeah,
older age,
Yeah.
all those things. But
Yeah.
yes, maternal hypertension can cause placental abruption.
Reactive is 2 accelerations in 15 minutes, isn't
20.
it? In 20 minutes, isn't
Yeah.
it, for a certain period of time?
Yeah, so up 15 beats over 15 seconds. So you have a baseline, so we have to go 15 beats above it and last at least 15 seconds. So they call it 15 by 15 on the floor, you might hear that. Unless they're under 32 weeks, then it's 10 by 10, 10 beats by 10 seconds. But I don't think you need to know that for this test.
I'd be
Next one.
nice to know.
Next one though, I think fetal monitoring is probably on the next one. But
Well, and you also have to realize you guys aren't gonna be experts at fetal monitoring. Lindsay's an expert. She's an expert. I used to be, but I'm not so much anymore. 'Cause I don't work with it like she does. But just understanding what you're looking for and what the monitor tells you, it's honestly telling you the placenta's function. Is it functioning at a level that's supporting the baby? And so, but just knowing what you're looking at and if your nurse is doing something and you're not sure what it is, ask has everybody felt like the nurses are really nice and are telling you stuff? Okay then, ask the question. They will answer you. They really will, don't you think, Lindsay?
Mostly.
Yeah.
Some of them are
And
really
if-
good at just doing it anyways.
Yeah.
Like the one that I had today,
yes.
she's also new now.
Well, and you might find it, but
Where are you with today?
I can't think of what her name is. Not the charge one.
Oh.
Or orientee or something, she has like a week left.
Yes, that's right. You were with Julie.
Yes.
Her orientation.
Both of them.
oh, Julie.
Julie's been there for 30
Oh,
years, but yes,
Julie,
yeah.
yeah, Julie's been there forever.
Oh, it starts with a J, right?
Yeah.
I was with her yesterday.
Lena or something like that.
Yeah.
Something like that.
Yeah, I was with
Anyway,
her.
but you can ask questions, and if you don't feel like you got the answer you want, we're there. So, or if the person was unsure or whatever.
Yeah, and if you don't get the answer during, like if we don't get a chance to talk about it during clinical, then just come find
Yeah,
us.
bring it up, yeah, exactly.
Because I'm always happy to talk about OB 24/7.
Yeah, she is.
Okay, any questions about that stuff? It's a ton of information, I know. Anything else, you guys? Oh, groupie strap. You want to talk about groupie strap?
We haven't really talked about that in my group, so,
Yeah, we haven't either.
okay.
So what is groupie strap? It is a infection, bacteria that grows in your vagina. Actually fairly common in women. For the rest of us, it doesn't really affect us. But if you have groupie strep in your vagina and that baby comes through the birth canal and you do not give antibiotics for the baby beforehand, they can get very, very sick. So, we give them antibiotics in labor to prevent that from transferring to the baby.
Is that what I asked you about yesterday?
Yes.
Okay.
Yep. Your kiddo had interesting case in peds, 3-week-old with mastitis.
A 3-week-old baby with mastitis?
with mastitis. And then they were trying
Okay, that's a new one.
I know. And then they were trying to figure out if she was also maybe having some groupie strep as well.
Well, they said in report that she was GBS positive.
Yeah, so they
The
tested.
baby was.
Uh-huh.
Wow. Okay.
So,
Well, and prophylactically, if they know ahead of time, they will do, what do you think they do for somebody if they were suspecting that the person maybe had that? What might they give the mom before? Pardon me?
Antibiotics.
You know what kind? Have you seen anybody with any orders, anybody?
we hit it on the floor.
Yeah, I think we have either.
Is it like Cipro, like they do for bladder?
Something fairly common.
Very common, super common. Yes,
Penicillin?
penicillin, yeah.
Penicillin.
Yeah.
Penicillin. So we do a higher dose at the beginning, you'll hear 5 million units, it kind of sounds like a
I
lot.
think that was over here.
So we start with 5 million units, I think your book says 2.5 million for the second dose, it's 3 on the floor, 3 million. So they'll get a higher dose at the beginning and then we'll keep doing it every 4 hours.
So if we've got a baby, let's say we've got a baby that comes and we didn't get a chance to do that. What would be the course of action then, guys? What would you think? If we've got a baby that maybe the mom didn't get any antibiotics and she's group B positive. Okay.
C-section?
Say that again?
C-section? Or
No, we've got a baby now and
Oh.
Delivery bag.
she delivered vaginally. So what might be looking for in the baby and what might we do for the baby?
Antibiotics.
Sometimes they'll do prophylactic
Yeah,
antibiotics,
sometimes we'll.
that's what we used to do, like as a rule.
Sure.
Anytime mom had fever in labor, anytime,
That's changed now, hasn't it?
yeah. So we would do prophylactic antibiotics, like especially I started at the University of Iowa and we did newborn antibiotics in the nursery. So we just did antibiotics on like every kid.
Which they kind of realize now, we don't need to really
Right.
do all that.
So we don't want to do that because that's how we get penicillin resistant.
Right. But what would you watch for in a baby if you thought it might be developing an infection?
Fever.
That's one of the later things.
Trick question on babies. It's the first sign of infection on a baby.
Rash.
Like lethargy?
Tired, not eating, would be signs.
You can check their son. This happened to me one time when I was doing and it can happen quickly. I was going to do a bath demo for the students and we were at a different hospital, we weren't at Methodist. The baby had just been examined by the pediatrician that morning, it had been born in the evening. And I was going through this exam and I had my finger in the baby's mouth and it wasn't poor suck reflex.
Yeah.
And the baby was just kind of, so I didn't say much, I'm kind of whipping through this deal and I go out and go, okay, something's going on and this kid had started to get infection. So poor suck reflex, lethargy.
So
Low temp.
Yeah.
speaking of the suck reflex thing today, so like when my patient had her baby this morning, the nurse like stuck her pinky in the baby's
Mhm.
mouth. Is that what she was doing? But this was like
She's-
right away, like right when
She's
the.
checking for the hard and soft palate.
Yeah, she's
and
probably,
tuberculosis.
that is too, but you can put your finger, I would, that, and the reason I had my finger in the mouth was because I was checking for the palate. Because but I was kind of suspicious because this baby was just, and of course you're thinking, oh, it just got examined.
Yeah.
That 2 hours ago, what could be wrong?
Yeah.
And that's how quickly babies can change.
But yeah, usually they'll have a low temp
Yeah.
versus a high temp.
Yep.
High temp at delivery, if mom has an infection, mom's infected, baby's cooking essentially, right? We're in an oven, so they'll come out with an elevated temp, but usually it's low temp.
Yeah.
And babies are signs of infection.
Yeah.
Takes a
But
lot
suck
of work.
reflex is an easy way
Yes.
just to see, okay,
Poor
well, how's
eating,
it?
poor suck, yeah.
Poor eating, poor suck, and then you can keep going and go, okay, I think something may be going on here.
Yeah.
And of course, I went and told them and they did something.
Labs, right?
Yep.
Just like
And then-
CBC, CRP.
And then we were giving antibiotics because the baby was.
Does that make sense on the groupie strap? Anything else you guys are just dying to talk about? Or are your brains now fried? like
Well,
usually when I'm done talking, people are
Yeah, we don't kind of glaze over. I don't glaze over, I love what you say.
thanks.
I'm always learning from Lindsay.
I
That's
learned
the thing.
myself, I got a whole new classes this summer, you know, I did that national certification
Yes.
exam, so
Like,
once you
oh,
graduate, you have to decide if you are in a specialty area, you can get certified in your specialty area.
I did find out on my exam that you can give vitamin K orally.
Yeah, it's not nearly as effective.
I know, but I didn't realize you could because I'd never done it before, but.
Yeah, so you get to learn all kinds of
Yeah.
extra stuff for that.
Well, and there's a reason why one of our learning outcomes is lifelong learning. Because, for example, do you think anything's changed in nursing since 1976? Yeah. You have to keep learning. And if you're not practicing in an area, like I said, Lindsay's an expert when she's looking at those monostrips. I used to be very much more adept and quickly seeing stuff. I mean, now if I study it, but just because I'm not doing the day to day like she has done. And the certification, there's certification for that.
And then like we have our national organization, our National OB Nurses organization does a special class on OB emergencies. So like even our charge nurses went to this class and I
What,
found it.
Are you?
A1?
A1, yeah.
Yeah, A1. ACOG, you'll also hear on the floor, that's our doctors.
Physicians.
So that gives us a lot of kind of guidelines for our protocols as ACOG and A1. But yeah, so I enjoy learning.
But that lifelong learning is one reason we put that in there because you have to be, no one ever knows it all and you just have to keep learning and keep up on what's happening.
One of our educators calls me I secretly like an adrenaline rush. So secret adrenaline junkie. I'm like, yes, I don't really, not quite as much as her. I don't really want people to walk in and seize on me, but you know, give me a good patient who's fully dilated when they walk in any day.
Well, and you know, you learn what your skill set is too, and then if you get in an area, maybe that's not your skill set.
And I feel like you get continuous opportunities to make sure your skills are up to
You
date
can.
because I have a black cloud.
Yeah, she's the SIG.
Yes. My coworkers will tell you that.
Or always when I work with
They
this
have
one
to work.
physician, when I always work with this one physician, no matter every really bad thing that's ever happened to me.
Yeah,
you are the
there's
nurse.
one midwife and I are like known, the two of us together, bad news bears.
Oh, Lord.
And I legit walked into work one day and she goes, "Oh no, you're here."
Yeah, it's not because she doesn't think you're a good nurse.
No.
That's not.
We
the
just
reason.
happened to have a delivery in the skywalk, which I showed my students where the delivery happened. Yeah, on the bench in the skywalk.
Yeah. Well, back in the day, this lady came in, there's maybe not even longer St. Francis in Waterloo, but the lady walked